All right, everybody. It's good to see everybody again, and welcome to this conversation, and that's really what it's going to be. The title is Advancing Primary Care in Texas, a conversation with three stakeholders. And in just a couple of minutes, I'm going to introduce each of them, and we'll get started. But you may have guessed that first we get to read the CEU statement. This live activity has been planned and implemented in accordance with the essentials and standards of the Accreditation Council for Continuing Medical Education through a joint providership between the Texas Academy of Family Physicians, thank you, Tom, and the Texas Health Institute. TAFP is accredited by the ACCME to provide continuing medical education for physicians. It designates this live activity for a maximum of 12 AMA credits. Physicians should only claim credit commensurate with how long you've been here. The views and approaches in this activity are offered solely for educational purposes. TAFP disclaims any and all liability for injury. No one's gotten hurt so far, but okay. We're going to keep with that. Or other damages for all claims which may result from the use of information presented. Material contained may be graphic. That hadn't happened either, but you know, it's early, so there's more. I guess we should view or advise. It's intended for clinical use only. It's the policy of TAFP that all CME planning members, speakers, staff, and providers disclose relationships with any ineligible organizations. Disclosure documents are reviewed for potential conflict of interest. If a conflict is identified, it's resolved prior to confirmation. Only those participants who have no conflict are involved in this activity. We're almost done. This session is eligible for CME but not CNE. So what that means, half of the discussion. To claim contact hours for this session, you must attend the entire session and submit a completed evaluation form. Okay, good, that's done. So we're really excited about this session. And I think that Bob Phillips, hopefully most of you had the opportunity to hear his wonderful presentation. I think Bob really set the stage for what we're going to talk about today. And I think Bob clearly has an understanding of the lay of the land, if you will, in Texas, whereas not everyone does. And I think all of us have heard many different policy pundits and experts talk about things that happen in other parts of the country and other states and sort of scratch our heads and think, are those things possible in Texas? Now, I guess the eternal optimist in me says anything is possible, but I think somebody like Bob Phillips really kind of tempers that with a dose of reality. So just a couple of comments to sort of set the stage. And I think it is fair to say that primary care is having a moment. Bob talked about the 2020 NASM report, which was really big. Think about it. The previous big national policy paper was in 1996. So that's quite a long time. So I think there is a lot of interest, there's a lot of excitement. And the other thing that Dr. Phillips did was sort of lay down a challenge to us and say, I think that there are a couple of areas in which Texas could lead the way. He talked specifically about graduate medical education. We have 16 medical schools now, and he certainly raised the issue of the distribution of those funds. Are those graduate medical education funds appropriately distributed to meet the needs of our state? He talked about payment reform. He felt like we could do something in that area, and also in monitoring primary care spending. And so today, we're really fortunate to have three very distinguished panelists that will address some of those topics that Bob outlined. And I think part of the beauty of this panel is that they all have different perspectives. We have a practicing physician, Dr. Lalani, next to me, who I'll introduce in more detail in a minute. We have a policy expert, Helen Davis. We really have two policy experts because we have Tom too, but he's a double duty guy. So Tom's role today is to talk about the political realities as he sees them. So let me just briefly introduce them. Helen Davis is Associate Vice President of Governmental Affairs of the Texas Medical Association. She's responsible for healthcare policy research, development, and advocacy on diverse state and national regulatory and legislative issues. Among the policy issues managed by her department are health insurance coverage, including Medicaid and CHIP, women's and children's health, behavioral health, primary care and emergency medical services, and trauma. And as Helen said yesterday, it's all the things that don't pay. So that's the way, it's a joke, okay. But that's Helen's and so much more of her expertise. Helen is a graduate of Washington University in St. Louis, as is her son, going to be, I think, right?
University of Denver.
Oh, Denver, okay, I thought he was at WashU. And she's the recipient of 2 Distinguished Service Awards from the Texas Pediatric Society for advocacy on behalf of children and pediatricians in Texas. And to Helen's right is Tom Banning. Tom is the CEO and Executive Vice President of the Texas Academy of Family Physicians. He directs overall strategy and legislative strategy, grassroots, political action, continuing medical education, membership and communications, and TAFP is the largest medical specialty society in Texas with over 9,000 members. Tom also has a previous life as a journalist, right? Yeah, kind of a journalist, okay, which helps understand his perspective on things. He has been really a moving force in this state to do some very important things. He's helped pass key legislation for tort reform, yes, patient protection and managed care laws, and numerous other public health initiatives. So Tom is a great friend, as is Helen, and we're really thrilled to have them. And last but certainly not least is Dr. Suleman Lalani, to my right. Dr. Lalani is an internal medicine physician who has practiced in the greater Houston area for the past 2 decades and in Sugar Land. Is there really sugar in Sugar Land?
It's the sweetest part of Texas.
The sweetest part of Texas, okay. I always wondered what this Sugar Land, okay. In the early 90s, I love this story. He came to the United States to begin his medical career. And he chose the United States because here's where medicine was the most advanced. Here's where the greatest quality of healthcare was provided. And this was the greatest nation. But he was shocked to discover how inequitable healthcare was in this very wealthy nation. And so throughout his career, Dr. Lalani has really tried to shorten that gap through his own practices and charitable endeavors, which are many. And I need to share with you that Dr. Lalani is the Democrat candidate for House District 76 in Fort Bend County, Sugar Land. I will say also that he is endorsed by the Texas Medical Association, Texas Academy of Family Physicians, Texas ACP chapter, but I will also say that Texas Primary Care Consortium does not endorse candidates. However, we are very happy to have Dr. Lalani here with us. So with that, what I'd like to do is ask each of our panelists to spend up to 5 minutes, really just sort of on a high-level overview of what they see coming down the pike in terms of health policy. And particularly something, maybe it's a story, maybe it's why they feel so passionately about their work that they do. So this is kind of the free-form part of the session. So Tom, start with you. No?
Sure.
Okay.
Let me get this on. So thank you, Sue, and thank you for having me today. I kind of need to be careful about what I say since I see so many of my members in this room. I don't want it getting back to my president or my board that, I said something, I'm going to say something that ultimately is going to make somebody gasp. So just be prepared. As Dr. Bornstein had mentioned, I've been with the Texas Academy of Family Physicians now since November of 1998. So I have seen a lot of stuff happen in Texas. I've seen a lot of stuff happen nationally. Before that, I worked for a political, we lovingly called him a hired gun sociopath, but a political consultant that ran campaigns, represented Fortune 500 companies, at the time represented the Texas Medical Association, among others. And before that, I worked for the Dallas Morning News at their Capitol Bureau in Austin. So I've got sort of a different perspective that sort of influences my view on healthcare, my view on politics, and my view on policy. And it used to be, not too long ago, that, you know, people could agree to disagree respectfully. You could argue and go out and have a cold beer afterwards and, you know, tease each other about, you know, their whether you won or you lost, and no one took it personally. Over the last, let's just say, since Facebook or social media came onto the scene, I think things have changed considerably because people are able to say things without ever meeting somebody or sitting down and hearing the other side, that has changed the political dynamic. And unfortunately, that's where we find ourselves today. When I was, you know, kind of coming up through the ranks, I was incredibly fortunate to be mentored by probably two of the best lobbyists that have ever walked the halls in Texas, Kim Ross and Alfred Gilchrist, who ran the Texas Medical Association for almost 20 years. And during their time there was no stronger organization in Texas than the TMA. If you wanted to pass a bill, you needed TMA support. If you wanted to get elected, you needed TMA's endorsement. And you know, they had some key takeaways that have stuck with me throughout this time. Number one is that politics ultimately drives or determines policy, and that is who you elect, what committees they serve on are going to determine the viability of making a policy decision happen. And you know, for physicians, that's a hard thing to appreciate or understand because they're generally linear thinkers, right? Patient comes in with a certain problem, you work up the patient, you make a diagnosis, you come up with a treatment plan, you get them out the door. Well, that ain't how politics works. So when doctors think about policy, you know, I've got a great idea to solve Texas's uninsured problem. Maybe the greatest policy ever that would save, you know, gazillions of dollars. If the politics don't fit, that policy is DOA, it's non-starter. And unfortunately, the politics in Texas post the Affordable Care Act have made healthcare pretty toxic from a policy standpoint because politicians are viewing healthcare as a blunt instrument in how healthcare is going to beat me in my primary. So politics is now trumping good policy ideas even more so. Also, partisanship and political power have taken on a whole different meaning than maybe what it had in the past. I was with a former Republican state representative a couple of weeks ago who, you know, retired about 2 sessions ago. And he was just bemoaning the fact of where things are today. And he said, you know, we used to think about, you know, our jobs with 3 Ps, politics, partisanship, and policy. And it used to be policy could win the day if you had a good argument and it made sense. He said it's been flipped. Politics is now first and foremost, followed by power, then partisanship, and then politics, and then maybe policy. And when you think about some of the issues that we have dealt with in the last 2 years, guns, COVID, abortion, politics has trumped everything from a clinical standpoint and from a policy standpoint. And that is really, really, really hard for people like me to square and in terms of moving forward policy changes that would improve the healthcare of Texas. But, you know, the reality is that politics is the art of the possible, and if the politics aren't right, the policy probably ain't possible. So what you'll hear me talk about today is going to be within that frame. I'm cynical by nature. I'm a very positive person generally, and I'm going to do my best to not go down an easy path of just saying we're all screwed and we might as well go home and you know, drink ourselves to death or whatever. So with that, I look forward to the conversation.
Disclaimer from the TAFP was about injury and all that kind of stuff. Now, okay, and graphic content. Now I get it. Okay.
We need to shorten that up.
Yeah, we do. No, it's all good. It's all good. Thank you. Helen.
Wow, okay, that's a tough one to follow. I'm going to try not to punch you as an act of violence. No, Tom and I have worked together for a very long time, and I really agree with just about everything Tom has said. However, I'm going to step back a little bit. You know, when I was growing up, I was raised by my grandmother, a high school English teacher, and she loved to quote poetry. And it's about this time before the legislative session, whenever, you know, you start thinking about, oh God, here it comes. It's just like waiting to deliver a baby, for those of you who've done that. It's painful and long, and in the end, you hope to have something you really enjoy. But the legislative session is hard, and you, knowing the politics going into it, you have to be realistic. But my grandmother's poem always hung on her refrigerator, and it still hangs on mine. And it's an Emily Dickinson poem that you probably all know, which is, "Hope is a thing with feathers that perches in the soul and sings the tunes without the words and never stops at all." And if you don't have hope, with a dose of realism, you wouldn't be in this job, whether it's politics or policy, and work in Texas, because Tom is right. It is a difficult political environment, a lot of partisanship. But at the same time, I would say that having worked with so many of the doctors in the room and nurses and others, I think that, you know, oftentimes you go into session and you think it's not going to happen, the politics aren't aligning. And then, lo and behold, you get a surprise, and stories from people in your district, hearing from their physicians, from constituents, from family members does make a difference. And we've had examples of that in the past, and I hope we will in this next session. You know, in 2003, the legislature came in after a huge Republican sweep and really decimated popular programs, including the Children's Health Insurance Program. And that resulted in quite a lot of blowback, and the subsequent legislative session, we had many of those cuts restored. And the reason for that is because constituents called their lawmakers and told them what it was doing. Hospital administrators, hospital board members, physicians, the press. I mean, so things did change. And I think you've seen some of that, you know, certainly with going to this next legislative session around maternal health. You know, at the end of the last legislative session in 2021, a bill to extend Medicaid postpartum coverage just hung by a thread. We really thought it was dead in the Senate after the House had worked very mightily to get it passed. And, you know, I was getting ready to turn off the TV and go to bed and thought, that's it. It's like 3 in the morning, and the bill comes up on the floor, okay? So again, you know, it was really easy to be cynical and to think that nothing that we said or did mattered, but in the end, you know, enough legislators heard from their constituents and the people they trust, their doctors and others, that we did get the bill passed. Not in the form we wanted. We didn't get 12 months of Medicaid postpartum coverage, we got 6. But it was a start, it's a down payment. That's typically how we do things in Texas, never, you know, not always leading by example in this case. But like today I was reading a story about another conservative state, North Carolina. They do have a Democratic governor, but they have a Republican legislature that has been just as oppositional to healthcare coverage as they are here. And Republican lawmakers there have decided they're going to support Medicaid expansion, and they call it that. They don't use semantics otherwise. And when they were asked why some of them changed their mind, several of them said it's stories. I talked to low-income moms who work 2 jobs and don't have health care coverage for themselves and what that meant to their family's finances. I talked to people diagnosed with cancer who couldn't get treatment, who may have subsequently died. So I do think that's really important. It's healthy to be skeptical and cynical, and a realist. But that's why we ask, for example, at TMA for our doctors to come down there and actually testify. I see people in the room who are down there all the time and speak with their legislators. So knowing the politics, and as Tom said, the art of the possible, things do change. We're now going to be in a world that's post Roe v. Wade. I'm not here to talk about abortion politics, but the landscape is different, where more people now who might not have thought about coverage for women or their families are now saying, we can't just, if we ban abortion and make it difficult for women to get it, then how do we support the women so they don't have an abortion in the first place? What does that mean? Okay, so that's an opportunity. That's a wedge maybe that opens the door, and someone who might have been against looking at health care coverage more broadly would reconsider. In fact, the last story I'll give, when we were working on the children's health insurance bill many, many years ago, I will not tell you when because I'm not going to age myself, but we did have a Republican legislator who was a key vote on a committee who was very against the bill. And then in a committee hearing, he said, if we pass this bill, does this mean some women would choose not to get an abortion because she would have health insurance for her child and that would make her family more financially secure? And he sat there for a second, and one of his Democratic colleagues said, yes, and others did too. And he said, I'm going to vote for this bill. So again, stories matter, day-to-day impact of everything you do matters, and there are days when sometimes I want to just cry in the shower too. But with that little bit of more optimism, I look forward to the conversation.
Thank you, Helen. You still want to do this, huh?
Well, thank you, Helen, for giving us a little hope, because after
Tom, I know.
Tom, I was thinking, what am I doing here? Well, first of all, thank you so much for inviting me to be on this panel and to attend this conference and get to meet so many good folks. So thank you so much. You heard that, I'm an immigrant. Many years ago, I made that conscious choice to come to America, because this is not only just the greatest nation, but the cutting edge technology, research, treatment was available here. And I've been trained at Baylor, and I've seen firsthand that this is true. We have cutting edge technology and research and treatment. But you know what? Who's who of the world can come and fly here and get their treatment, but our own people cannot cross the street and get the treatment done. And I was shocked to see the inequity of our healthcare system, and that kind of one of those things brought me towards this legislation. I believe everybody has a good heart and doing something, whatever they can do for people, and I did the same way, joined many nonprofits and slowly sitting in their leadership positions, seeing what can we do. One of my role, I was fortunate to be the ambassador to US Congress with Alzheimer's Association. And my role was to educate and convince the Congress about what the Alzheimer's is, what their need is, and what the need of funding is, and to release the funds in the name of Alzheimer's. Because what was happening was the Congress will give funds to neuro research or whatnot, and then the pie will be divided whoever was in power, where they thought of it should go. And when it comes to Alzheimer's, it was a very small portion. So we started to legislate and then kind of say, well, if you want to give money to Alzheimer's, give it in the name of Alzheimer's, so we exactly know how much we are getting. And that's where I learned how legislation works and how we can be effective. Time and again, you will hear those stories, right? We have in Texas the world's largest medical center, not just the US, world's largest, yet we have the highest number of uninsured. How many of us know some senior who's rationing their medications because they can't afford? How many youngsters who are doing 2 jobs yet can't afford healthcare? How many of people who are still, they will say they're okay working class, but they will delay their treatment or care, and they will just rely by nature to cure them. Some of them will get better, but imagine the work time loss, and imagine some people will fall into complication, right? To save that $200, somebody will end up in the emergency room, and we will be spending $200,000 on them, and some of them unfortunately will have complication, and the quality of life is gone, and somebody who is independent, productive citizen of the society becomes dependent. So we need to become more proactive in healthcare, and that is my thought process, to bring that human aspect of healthcare to legislation. So that's what brought me here to do that, to join our colleagues. You know, as a physicians, we do not make a lot of emotional decisions. There's a lot of thought that goes through it, right? So that's what I will say, that, you know, I'm ready to listen and learn, make my diagnosis, and then we'll have a treatment plan that follows that. And as a physician, we are being trained to break the hard news, deal with difficult situation, but still command the respect of our patients and their families, right? So I know that I'm stepping into a difficult situation, but I'm pretty confident that we can command respect from both the side of the aisle, because this is not something where a dictatorship would hold. I know we would have to compromise somewhere, we'll have to collaborate somewhere, and then get things moving. So I would like to be that level-headed person that will work along on both the sides of the aisle and get something done.
Wonderful, wonderful. So you still want to do it? Okay, good, that's good. Just checking.
One of the person told me before, like I've heard many people saying that, have you checked your mental status check, right? So one of the great politicians said, you know what politics is? And he said, Poly-ticks.
There you go.
Must be bitten by many ticks to come into politics.
I like your attitude, okay.
Poly being many and the other way being blood-sucking. I'll leave it at that.
There he goes again.
Thank you
Okay.
to be the graphic.
Exactly, exactly. All right, so there's so many things we could talk about. And again, we have the right people up here to talk about it. But I think consistent with the efforts of the Texas Primary Care Consortium, we're going to really focus our energy on 3 specific topics. The first one is access to healthcare, primary care in particular, and also affordability, because I think they kind of do go hand in hand. And this has been mentioned, it's been alluded to, it's something that no one is proud of in the state. You know, we like to be first, but not in this. And so, yes, we still have the highest uninsured rate in the country. It's estimated anywhere between 5 and 6 million people in Texas lack health coverage. Think about that. I think the population of Harris County is what, 4 million, 5 million? Yeah. So think about Harris County. Think about that entire huge Harris County, Houston, and all that. Those people, none of those people have health insurance. I mean, to me, it sort of helps me kind of visualize it. Part of the challenge is some of them fall into this coverage gap. Too much income to qualify for Medicaid, if adults in Texas could even qualify for Medicaid, which is a whole nother issue, and not enough for subsidies, so hopefully that is changing. The other thing about this is there's a significant health inequity, health disparity issue here, and that is that being uninsured disproportionately affects Hispanic and Black Texans. 27% of Hispanic Texans and 18% of Black Texans are uninsured, and that's compared to about 12% of the non-Hispanic, non-Black population. And as many of you know, along the Texas-Mexico border, the rates can be as high as 30%. And so we also know that having health insurance is associated with better health. So this is one of those problems. This is one of those seemingly intractable problems. But as Helen said, and I think even Tom would acknowledge, we have to keep at it. We have to keep pushing. And I don't know if Doug Curran is still here or not. Glenn, is Doug? Okay. I think about my good friend, mentor Doug Curran, who has, I don't know how many times has trod the Capitol and talked very passionately and I think very convincingly to legislators about these are the working poor in Texas. These are people that, 60 or more % of people that are uninsured in this state have at least one job and sometimes two, and certainly people in their household that are working. And so I think to me, that's always stuck. How can you, anyway, okay. So that's what the problem is. And so Helen, we're gonna go with our optimist here first. And so Helen, tell us some things that you are seeing that may address this chronic, severe problem that we have with uninsured in Texas, please.
Yes, well, you laid it out very well, and I think everybody in this room certainly understands the magnitude of the problem. I think it's to combine the population of Oklahoma and Louisiana together. So it's a lot of people who don't have health insurance. Now, everyone focuses on Medicaid expansion, which of course is a priority for many organizations in this room, including mine. Using Medicaid dollars to craft our own solution, and that would definitely make a huge difference in Texas, about 1 million people, more or less, who would be covered. And those are the working poor, that's who we're talking about, the vast majority of whom are people of color, women, working multiple jobs, and under the Affordable Care Act, it's of course childless adults who are not eligible for Medicaid at any other time, as well as parents. And when you look at who's eligible, many of them, based on national analyses, are people with disabilities that keep them from working regularly. People think when you have a disability, you might be eligible for Medicaid, but to be eligible for Medicaid and have a disability, you have to be pretty much homebound and unable to do anything. So that would be a huge win to get it done. Texas is one of 12 states that is a holdout. North Carolina may close that down to 11. The optimist in me wants to say that perhaps, there'll be more consideration of that next session. But even if we did that, that still leaves, about 5 million people, depending on which statistics you're using and who's uninsured, 4 to 5 million who are uninsured. Many of them are not eligible for any program, right, federal or state. They are eligible for local programs designed by hospital districts or other publicly funded entities. And these are people who are the undocumented immigrants or other mixed status families who are not eligible for the ACA. They're not eligible for Medicaid coverage if we did expand, with the exception of people who, green card holders, if you will. And that's a huge number of people who work in Texas, who live in Texas. And even if you pass health insurance in different forms, wouldn't be eligible. So what is the system you build for them? A lot of it is FQ8Cs, federally qualified health centers, the hospital-based systems, and of course, primary care, which is what we're here to talk about. We know that without those systems of care that are in place in communities, whether it's rural or urban, that many of those wouldn't have a place to go. That might be why HEB, for example, is opening up clinics that's no health insurance. You walk in, it's a set fee, it's based on primary care, and it serves people in the community, but you don't have to have health insurance. And so that's a very large number of Texans. I know in Dallas, Dallas County Medical Study, I see Dr. Walton. That was a big focus of theirs through Project Access. There are similar projects like that around the state that still existing state, but you have to have that network of people who, regardless of whether there's insurance, they can be seen and get into not just primary care, but specialists. Other initiatives that I think I'm really more optimistic about, I'm sure you've read about Texas's maternal mortality, morbidity levels. It's unfortunately, like across the country, one of the few developed countries where it's actually going up, not down, for a variety of reasons. But there is bipartisan support to extend comprehensive Medicaid postpartum coverage. We did do it last legislative session. It required a federal waiver. And if you haven't read about that, it's now stalled at the Centers for Medicare and Medicaid Services, quite honestly, over abortion politics, the wording in the bill. But when it was announced that it's unlikely that Texas will get a decision on the waiver, which means it's just stalled, there definitely was a lot of comments by people in the legislature, including the Speaker, of the House, among others, urging lawmakers to find a way forward next legislative session. There's in the hearings where this has come up, there's bipartisan support. And even many legislators who you wouldn't think would be supportive of a 12-month continuous coverage, made comments to the effect that, when the legislature reconvenes, this is a priority for them in a post-Roe environment. So again, I think that is a bright spot. There are other areas where there is still bipartisan agreement. Whether we'll move forward, I don't know. There's been several attempts at this. There are federal waivers to do what's called a 1332 federal waiver, where you're basically reducing the cost of private insurance by providing reinsurance for health plans who cover the sickest patients. And by doing that, you bring down the cost of health insurance so more people can afford it. That has been a bipartisan effort, and I wouldn't be surprised if that comes back. The other really big, important win, which is at the federal level, is, Dr. Bornstein alluded to, is extension of federal support for people who are eligible for coverage on the marketplace. So there was a temporary extension under one of the COVID relief bills, the ARPA bill, that provides basically for people who are purchasing coverage on the exchange a silver level plan. If you're of a certain income, there's almost no copay and your premium's almost zero, if not zero depending on your income. It's also reduced for higher income families who are buying coverage on the exchange. That was just extended under the Inflation Reduction Act for another 3 years. And just in the last about 2.5 years, 3 years actually, since we've had support, we've had about 800,000 Texans get coverage on the exchange. So by extending that support, that was very, very helpful. It also insulates them from rate hikes at about 10%, which are expected to take effect next year. So the combination of things will help tremendously. The one area and we can spend more time on this, where I think is going to be a rude awakening, is the end of the public health emergency. For those of you who don't know, when the emergency first took effect, legislation in early 2020 gave states additional federal matching funds for extending Medicaid continuous eligibility for anybody who was enrolled on March 18th, 2020 or later. So if you've been enrolled from that date forward, you get to stay on Medicaid, you have not lost coverage, even if you're technically no longer eligible. So who has that benefited primarily? Postpartum moms, a lot of kids, people who lost their jobs and didn't have health insurance and were able to get on because of Medicaid, to be a poor parent, no childless adults, but if you're a poor parent, you don't qualify if you make more than about $315 a month. So very poor people who got on, they got to stay on. That PHE has been extended every 3 months since 2020. It's likely to get extended again in October, and then that's probably going to be it. And when that happens, states have to unwind Medicaid continuous eligibility. So there's about 1.5 million people or more the state estimates are probably unlikely to still be eligible. Some of them will be eligible for the marketplace coverage based on these additional enhanced premiums, but a large number will be uninsured. So if you think about that over the last 2 years, that's going to be a rude shock to the system when suddenly a lot of people who've had coverage aren't eligible anymore, and they're going to have to be transitioned to another program if there is one, and there may not be one, right? So that will happen likely during the middle of the legislative session. And again, that might be one of those just events that happens that causes legislators to rethink their approach, because we won't get into all the details now, but the state is not equipped to handle that number of people who have to go through Medicaid redetermination. And I promise you, your hospitals and practices aren't ready either. It's going to be a huge, huge chaotic event, even with the best laid plans by the state, which they are trying to make this work as smoothly as possible. So that could be an opportunity. It also could be a real setback, but there we have it on the uninsured. Unless you want me to elaborate on something else.
Okay. Dr. Lalani, when we talked yesterday, you talked about affordability as important issue for your patients, the patients that you care for. And I think, when we start talking about access and sort of teasing out access, there are a number of different components to that, right? Yes, you need to have insurance, but that doesn't ensure that you have access. And even if you do have insurance and access, if you can't afford the care that you're seeking, then that's an issue. So do you want to talk about that?
Yes, so there is a big issue of insurance, no insurance, but there's also issue of underinsured people and affordability that comes into play. When we were talking, I was reminded again, I was telling her that I actually had a patient, this is not a story, plus I'm sure you will have similar stories. Ms. Jones comes to the clinic and you see that her sugars are going up, not compliant. I said, I know you're not taking your medication. She said, no, Dr. Lalani, I'm taking my medications. Promise you, this was just happened. This family came and we had a party and whatnot. Okay. Next visit, again see, I said, you're not taking medication. No, I'm taking it. I'll do that. Third visit, now I know that you're not taking it. Here are the results. And then she had the shoulder, put her hands on my shoulder and says, Dr. Lalani, this medicine is not covered by my insurance. I got so freaked out, upset, and I said, you know what, go to Walmart. This medicine is available for $4. Go get it. Why are you not getting it? She took a deep sigh and says, you know that I'm on 8 medicine, and my husband is another 8 medicine. 4 times 16 is a number I can't afford on my Social Security check. And I came home that night, I talked to my wife, and I literally cried that I wanted to be extra smart, and here I'm telling her, and then she taught me a life lesson. And these are real issues that are happening. So we need to make sure that we create systems in place where these medications are affordable, this access is available. I talk to a lot of my colleagues, in legislation, I say, I'm not asking you for more money. We know we're already spending tons in healthcare. Why not we become smart about it? You walk to any hospital and walk in any emergency room, you will see more than half of the patients are there who could be treated outside. If they have an access to health care, we can prevent the complications from happening. And then we will prevent a lot of money that we are spending on that part too. We just have to be more proactive and more smart how we will utilize that. And that is one of my goal points, to come and talk to the legislation. That we are doing it, we are spending out of it. There was a study out there, 85% of the Medicare beneficiary dollars are spent in the last year of their life. Mm-hmm. That means what? 2 months of ICU? This could have been happened and prevented, and they can be spread over 20 years, 30 years. The quality of life will improve. These people will be a productive citizen of the society rather than dependent. So we need to be more proactive in healthcare.
Tom?
Yeah, I think it was Churchill who said America always does the right thing after they've tried everything else. And that's kind of where we are. Despite what many people think when they listen to a politician who wants to go and improve schools or fill the potholes or expand transportation lanes, politics is reactive. It's not proactive. So until a crisis occurs that forces them to take a potentially career-ending vote, which is unpopular, they're not going to do it. And when you think about the uninsured, there were a couple of events that occurred this year that by definition are going to create windows of opportunity to do something politically proactive that may have been unpopular in the past, that the dynamics have changed. Helen touched on coverage for pre and postpartum. I'm confident that that bill is going to fly out if it's not an emergency item on the governor's list, because he is getting his ass kicked on the campaign trail because of it. Similarly, there's likely going to be a carve out for behavioral health services because of Uvalde, when we pointed the finger at mental health and not guns. So I think that there's opportunities that the environment have created that we are going to take advantage of. When it comes to broad Medicaid expansion, you still have a problem with the Senate. I think that it would pass the House with overwhelming majorities, but the Senate is governed by one individual, and the Lieutenant Governor is not interested whatsoever in having a conversation about Medicaid expansion. Now, I will tell you, if a hospital collapses or closes because of financial reasons, imagine Parkland closing up because they're overwhelmed with uninsured patients. That's a political crisis that they cannot ignore. It's kind of similar to what's happening in Georgia right now, where I think the second largest, the one of two trauma hospitals in Atlanta is closing.
Atlanta Metro.
That's going to force the government, Georgia, to decide what to do about that. And that's really just, again, trying to look at what political opportunities there are and using an unfortunate or horrific situation to drive policy change. It shouldn't work that way, but it does. Now, on a positive side, I do think that there are some things that we passed last session, specifically the all payer claims database, that's actually going to give policymakers independent, verifiable information on where we're spending money smartly, where we're spending money stupidly, and help us advance good policy going forward using state data. Nothing happens quickly. I mean, the legislature is not set up to pass bills. It is really, really hard to pass bills. So it generally takes multi-sessions to do something meaningful. So you nibble around the edges, you take what you can get, and you move forward, and you come back next time and ask for more. And I think that that's where we're at. I wish we could get up there and hit a home run and knock it out of the park and solve our uninsured problem, but we won't. But I think we'll make some a good single or a double, and make some progress in covering people. And as more states change, like North Carolina or maybe Georgia, and expanding coverage, and as the feds become more engaged in trying to incentivize the states that have not done this to go forward with coverage expansion, those opportunities will present themselves. But I just don't see it beyond some of the things that Helen had mentioned. And I do have to correct one thing that you said early on, Sue, when you introduced Helen. You said a policy expert.
The policy.
She is the policy
Yeah.
expert in
Yeah.
Texas, and I think you can see why.
I think you can, and I certainly, yes, absolutely. It is very true. All right, so we got a couple of options here. So I think we allocated 5 more minutes till questions, right? So what I'd like to do is kind of do a lightning round if we can. And I had 2 other topics that we wanted to discuss, but I do think payment reform is the one that we probably should talk about. And I just want to kind of set this up. And so I think it's very clear that one of the things that the pandemic did very well, if you will, was show the very fragile state of primary care practices. If you look at the Larry Green Center, if y'all have never looked at the Larry A. Green Center Primary Care Collaborative website, back in, I guess it was in March of 2020, so maybe the second real month or the first real month of the pandemic, they started doing national surveys every 2 weeks of primary care practices and the people, the physicians and the nurses and also their patients. And it is quite a chronicle to really see. I think it chronicles the story of primary care under duress in the pandemic better than anything. But, practices learned to pivot quickly, and because they had to telemedicine, practices that had never done telemedicine. You remember early on we tried to provide vaccines, but that was not really with just the Pfizer vaccine, with the issues with keeping it cold. So I think primary care practices did as best they could. I mean, they had testing clinics in parking lots. You remember that in the early days of the pandemic. So primary care practices rose to the occasion the best they could, but the decades of underinvestment in primary care had very predictable outcomes, and that, combined with the predominant payment, fee for service. And I'm looking at you, Regina Rogoff, because I know you have different views about that, which we'll hear about tomorrow. It's very interesting. And so, you know, it became clear, I think, very clear, that something had to change in terms of payment, because with no safety net and strictly relying on seeing patients face to face, there was no survival for many practices. And so let's talk just again a little bit, maybe briefly, about that. Dr. Lalani, yesterday you just said flat out primary care physicians are underpaid, period.
It is. I mean, you know, it's not a myth. That's a fact that is happening. You know, we all are in this race where everybody's looking at the bottom line and the numbers. And I say we are taking a forest view and forgetting some of the trees out there. You are, as a system, we want to save money, but we are blinded to the community which is actually saving you money. And so I think we need to refocus in this area. You know, a lot of these people, I mean, if you ask a lot of young aspiring doctors, like, what field you want to go, you don't hear a lot of people telling that I'm going to go in primary care, because they have seen the long hours, they have seen the practice, they have seen the stress and all of those that goes through. So I think we need to appreciate that this is an underappreciated field, but this is the field which is actually going to save you money. If these are the people who are the gatekeepers, are going to prevent the complications, so you will save money in the long run. These are the people who will save the people to go to ERs. That's where you're going to save money. These are the people who's going to save for having complication of CHF and diabetes and stroke. These are the people. So I think we need to refocus and make sure that we equip them smartly. And the reimbursement, you know, a lot of extra work that has come up. You know, you have to hire another staff to do quality indicators. You have another to do the pre-authorization and all that. Who's going to pay for that? So all of that extra stress that all comes through. And you know, we have unfortunately had this corporate players that have come into. And then I see it, I may be politically wrong saying that, but you know, we're treating humans as numbers. These patients are not an extra file. These are not the number, somebody in room 7. This is somebody, human, Mr. John, Mr. George, Mr. Muhammad, or Judy in the room. And we need to treat them as humans. And you know, when you do good practice, money follows. But unfortunately, sometimes we are blinded and we go after the numbers, and that's where the catastrophe happens.
Yeah. Tom, you're kind of an expert in this field, so can you do a value-based payment for
Sure.
I wouldn't say dummies, because nobody's dummy.
I'll be relatively brief. I think that when you look at where the market's moving, the value that is being placed on primary care to manage continuous, coordinated, quarterbacked care is huge. Wall Street sees it, and why they see it is because the feds are trying to get out of managing the Medicare population. It's why you're seeing a rush to go into Medicare Advantage. It's why you're seeing so much of an initiative and an effort to go into accountable care organizations or coordinated care organizations. So I think that people are understanding the cost trends that we're on are no longer sustainable, and we really need to redouble and reinvest in those areas that really improve outcomes, improve population health, and that's what, you know, primary care does day in and day out, helps patients navigate a very complex system. From the state perspective, a couple of things are happening. You know, in 2020, the Speaker of the House at the time appointed a committee, a select committee on healthcare costs. Unfortunately, COVID happened, that committee never met, disbanded without a report or holding any hearings. This session, or this interim, a new speaker actually created a new committee looking at healthcare reform. It's chaired by a gentleman down in Houston named Sam Harless. But what's interesting is the chairman of the Appropriations Committee, the chairman of the Insurance Committee, the chairman of the Human Services Committee, the chairwoman of the Public Health Committee, and other big-time legislative players are on this committee, and they're looking at state-level solutions to get our arms around cost. And you got to remember, the state has limited levers of power that they can pull because, you know, they can't do anything to Medicare. Medicaid, they can play with a little bit, but they're still governed by federal rules and regulations. 60 to 65% of Texas's entire market is ERISA, so we're preempted from doing anything with ERISA. So you've got maybe 10 to 12%, which are fully insured, which we can mess with. And we've got the teachers' retirement system and the employees' retirement system of Texas, which is basically, well, the ERS is sort of like Texas's employees that we self-insure, so we can do whatever we want with them. The teachers are a little bit different, but I do think that even the cost trends that we're seeing in TRS and ERS are unsustainable, and the legislature wants to come back and say, how can we better spend our dollars? And there's a lot of conversation around investing in primary care, trying out alternative payment models, trying out alternative delivery models, which is really exciting. And you're absolutely right. When you think about fee-for-service, generally it rewards high volume, high cost specialty care, and undervalues primary care, which provides, you know, continuous, longitudinal services. So, you know, the National Academy's reports come out. There's, you know, stacks of reports up to the ceiling that say the same thing, but people are finally paying attention. And I will conclude with this, which is probably as exciting. The employers are finally paying attention, and they're saying, what are we getting for our premium dollar? Why can't we spend it differently and get more value out of it, where our employees are actually getting healthier rather than having things done to them? And that's a different level of engagement that they have not been part of in the past.
Helen, thank you, Tom. Helen, some closing thoughts about that?
Yeah, no, I agree. I think we're at this interesting moment where Wall Street and big private equity, venture capital, all very interested in primary care because that's, you know, really where the money is. If you want to save money, you have somebody who is organizing your care, directing your care in a way that is efficient. Yet the people who are actually providing the care aren't necessarily benefiting from those investments. And so how do you translate those investments into a sustainable system so that people want to go into primary care? In fact, I was looking at an article today that talked about, you know, for this focus on team-based care and the direction and all the things that primary care physicians are supposed to do, everything from making sure you have, you know, your annual exams, your mental health services, that you're getting your social supports, food security, all these things, team-based model. You know, you're talking about from a practice revenue cycle, it's about 2/3 of your revenue would have to come from non-patient sources. So think about that. That's a huge change in how you pay. That means you have to move towards these prospective payment systems that support that. And so we have this misalignment. So it's very exciting in a way because, you know, for people who've worked in primary care for a long time to see this level of interest. But you hope it can't just be about expecting primary care physicians to do more with less. Yes, we have lots of money in the system, but how that money gets translated, to the systems. And I also think it's important that patients understand that this change that's going on. In fact, I was thinking about it this morning. You know, when I was a kid, I had the same doctor who delivered my dad and my aunt was the person who took care of us when we went to see my grandmother. So it was a family physician. That's who I thought of. That's my primary care physician, Dr. Rose. Now when you go see your primary care physician, I might not even see my physician. I might see the nurse practitioner, the PA, somebody else in the office. It's the team though, and I know if I need to reach my doctor, he's there. And so that difference in thought, depending on your age and generation, that's a big change in how people organize their thinking. So there's lots going on. It's exciting, and I think what's really important is groups like this are directing lawmakers to set up systems that are sustainable and rewarded, not just keep basically doing the same thing we have been doing, which is
Feeding the beast.
yeah, feeding the beast. That's a good way to put it. Yeah.
Feeding the beast. And so, yeah, that reminds me of what Bob Phillips said today, which was one of the 5 pillars of the NASM report, and that was actually the first one, and I think I have it right. Primary care teams should be paid for caring for people, not physicians for delivering services. And if you think about that, that's pretty revolutionary, right? I mean, this is what you're saying. It really underlies the whole different way of doing business. And the other thing that I have to say is, I'm paraphrasing someone who once said, "Who knew healthcare was so complicated?" I think you remember that.
I think my 21-year-old son just said that.
Right,
Trying
he
to
said,
get
yeah.
healthcare.
But you look at like Amazon, you're like, whoa, what? It's not that simple. If it was that simple, we would have figured it out a long time ago. So what a great, rich conversation. So we do have time for some comments, and we don't have any extra microphones, but if you want to put your question in the QA on the app, I bet you we could hear people if people wanted to stand up. I bet you could, Dr. Griggs. Another on the writing committee of the NASM report, right there, Jackson Griggs.
That's
Excellent.
a lot of work.
Way to go.
Well, first, we all sleep better because of y'all's legislative policy leadership. So thank y'all for the way that y'all are leading. And while there is a mix of both despair and hope, my hope is increased because of y'all getting up and doing your work so well. The question has to do with this window of opportunity right now around mental health. Those windows opportunity are few and far between. And wanting to capitalize on this for primary care, which has been, I like the term that it's the de facto mental health system in the United States is primary care because the majority of services, mental health services are provided in primary care, was just reaffirmed last year by a Graham Center, a troop of writers that studied this just recently published. So how do we get the message? What's the play for primary care? How do we get the message to our lawmakers that funding mental health services in primary care is the key as opposed to other avenues?
Good question.
At FACP, we probably around 60%, maybe more, of our adult patients have diagnosed with mental health conditions, and we need that support so that we can address them. And so I'm curious to know what y'all are thinking about what the play is there.
Well, in fact, TMA and TAFP, along with the other primary care societies, collaborate regularly on testimony, and we have submitted testimony on this to several committees talking about that very thing. I mean, when you think about mental health, the go-to now is you think about mental health professionals, social workers, psychiatrists, and those are all really important components, but we know that when families are in distress, or children themselves, who do they often go to first? The majority of the time it's to their primary care physician. It could be a postpartum mom who seeks care from her OB-GYN, or the pediatrician detects there's something going on and screen for it, or just, I myself go in and talk to my doctor. So that is one of the things we're really trying to broaden the conversation. There are not enough mental health professionals in the whole nation to fill the need. Much less, just Texas in the wake of a horrible tragedy, which unfortunately seems to happen all too often. So it's both, and I think all the mental health professionals would say the same. The Texas Child Mental Health Consortium, many of you in the room may know about the Child Psychiatric Access Network, who provides consultations to primary care physicians for mental health services. The consultation is the mental health professional with the physician or other healthcare provider, and they know that they can't do it all, so they need to be able to have the primary care physicians in the field who can manage those patients. Some of those patients might not want to ever travel somewhere far away, can't get there, whatever it is. So I think it's more part of the conversation, but I do think helping legislators figure out what the payment model is, because FQHCs are a different animal than primary care physicians, just in small physician practices, and we haven't really found a payment model that works. Certainly the collaborative care model was meant to, but it's based on a Medicare chassis, and it doesn't really work for pediatricians. So I think that's going to be the real question: is how do we design the payment model to reflect that need, and also recognizing that, you know, some of those services are going to be things like CPAN or something like it. I know there's CPAN, they're developing one for moms, PeriPAN. So, you know, you're absolutely right, and I think the payment model is going to have to be what's really critical, so that, you know, I've heard so many primary care physicians say, I really want to do this work, and I do it, but at the same time, you know, I as a small practice can't afford to do much more because we aren't being paid for it. So that's the piece we've got to figure out. Tom may have some other suggestions.
I really don't, other than we need to begin integrating it into our training early. I mean, you know, you think about, you know, how long it took baby aspirin to become the norm. It was 17 years before it became the standard. You know, we don't have that long. But we need to begin training everybody on multidisciplinary training and understanding how to best utilize everybody and breaking down the silos that we've had for decades on training. Well,
and again, a shout out to your practice, Jackson. So if y'all are not familiar with the Waco Guide for Psychopharmacology, you should be, because that is a great tool. And I think it was, I don't want to say out of desperation, because that's a little, but maybe, okay. So yeah, and so check it out, it's online. I think y'all are presenting, you're presenting here, at the summit. And so again, it's a tool to help primary care docs. I'm looking at Janet Hurley, my good friend, and thinking, you know, when I first met Janet, she was like, there were two things I said I wasn't going to do when I went to, one was take care of adolescents with behavioral health problems. And it's like, oh, well, I guess I am, because I'm the one here in White House, Texas. And so, yeah, the imbalance between the demand and the people that can actually do it. And then add to that Spanish speaking on top of that. And so, I mean, I think telemedicine telehealth has a role in it, but that can't be the only answer. So it's a great question.
But I had a pediatrician say to me not too long ago, like, you know, with the arrival of CPAN, you know, she really tried to resist not going down that road with, you know, kids with really complex behavioral health disorders. And now she's like, you know, I get the backup. I feel confident that I can manage this, and I know I can reach out to somebody. So I do think those collaborative relationships are really important, while recognizing, you know, she's not getting any additional payment for doing that. The CPAN we want to support, and so, you know, you're going to have to. It's having the you know, knowing that you can call somebody and they have the expertise, but also that your time is in your nurse's time, and if you have a social worker in your practice or other support service, they're getting paid too.
Did you want to say something?
I think the payment and reimbursement is the important part, but we also have to realize that mental health and physical health cannot exist in their silos. There's a lot of overlap happens, right? The person with CHF has a different hospital stay versus CHF and depression, and the length of stay that will happen, right? So how are they going to manage the other things? So a lot of chronic illnesses, how mental health plays a role in that part too. So raising awareness, education, not only just for the general public, but also from the provider side too, that you need to look at these signs and what is happening. And then that's what I want to bring, that physical and mental is no different anymore. We have so much things that are going on.
It's a great point. And I don't know if we really have time. This is a very good question, though. There's a discrepancy between funding for pediatrics and geriatric population. Millions are spent into life care, but pediatrics is underfunded. How can we invest more in our children? And I remember, this reminds me of when we first went down the patient-centered medical home route and we talked to our payers. I remember this so distinctly, and we were looking at to do our pilot, our PCMH pilot, and we said to the payers, well, here's some pediatric practices that really want to do this. And the answer was, there's no return on investment for children. I was like, wow, okay. Maybe in a year or a 2-year time frame, but in a lifetime time frame, you bet there's an ROI. So again, I think that it's a very important and true point, and I don't know how we do that, but you know, investing at the front end is a whole lot, you know, in health and healthy behaviors and all those kinds of things. So I don't know if y'all have any.
Talk to your legislators.
Talk to your legislators.
I mean, state and federal.
Well, that's the point I wanted to bring out too. I understand politics is like a train. You know, it's not a car that you make a U-turn, and it will take a while to make its own turn. I also understand that It's not a matter of understanding, it's a matter of priority. So I want to kind of leave this thought, or maybe give the homework, that we need to start a good trouble. When we see a lot of our patient population, a lot of general public, our friends, a lot of people I hear, they will tell me, I'm apolitical, it doesn't affect me, I just do my work. And I have to tell them, no, politics affects every aspect of your life. So we need to start educating our patients. Every clinic, every hospital, every provider place should have the pamphlets telling them what is our need is, what we need to work on. So they need to make sure not only they vote the right people in, because that's what, if legislation is only good as the people who are running it. So you need to elect the right people, but then again, be educated enough that make their life miserable, that there should be accountability, and they should take the priorities, right? So we need to be proactive, not to wait for the catastrophe to happen, but to be proactive, working on all these things.
So can I say just one
Of course
real
you
quick
can.
thing?
Of course
So,
you can, Tom.
the secret sauce that primary care has is a relationship. And there was an old country doctor that I know that told me a story about a patient that he had delivered her daughter, delivered her granddaughter, worked for him for, I think it was 38 years, somewhere right around there, who ended up having stage 4 cancer. Went to the best specialist in Dallas and came back and said, all right, Dr. Curran,
No
we've come up with
PHI,
a treatment
it's okay.
plan, here's, what they're gonna do, and he sat her down, he said, I love you, and I've been with your family, and you've been with me for 40 years. Let me tell you what this is gonna do to you emotionally, financially, physically, and you've always talked about spending time with your grandkids and taking them on a trip to Europe. I want you to go home and pray about what you want to do, but I'm going to be honest with you about, what this course of treatment is going to mean. And, I'm going to support you in whatever your decision is. Well, came back and gave him a big hug and said, thank you for having that conversation. I'm going to spend the rest of my years loving on my kids and spending my money and traveling, and just promise me there's not going to be any pain. He said, we can take care of that, no problem. So, having that relationship and that ability to communicate with patients, that's the power that we're talking about in this room, and that's what changes systems like that.
I think we can't think of a better way to end this conversation. So please give our panel, really, really good.